So welcome everybody, and thank you for attending the plastic surgery panel tonight about short-term medical missions versus surgical capacity building and whether both frameworks coexist with each other and can support each other. Just a little bit of baseline rules. Please keep yourself muted and your video off, and please ask any questions that you have in the chat. To begin with, I'll first start by introducing Dr. Amanda Gosman. She's the chief of the Division of Plastic Surgery at UC San Diego, and she's also the director of Craniofacial and Pediatric Surgery there. She's also the founder of ConnectMed International, which is a telemedicine organization for global surgery. So Dr. Gosman, why don't you tell us a little bit about yourself?
Well, thank you for the introduction and for including me. It's really an honor to be here and discuss something near and dear to all of our hearts. I will just preface, you know, this conversation with my end game for going into medicine was really to have a career in global health, and it's been really kind of a hodgepodge of an education, trying to figure out kind of what is the best model for to play to my own strengths, and then what I felt was really going to be most impactful. So I feel like I've experienced a lot of different models. I took a year off in medical school and lived in Guatemala and worked on a bunch of fincas providing primary care, and then worked on a mobile surgical unit in the Amazon basin, doing surgical care in the back of a truck. And that's where I first learned about telemedicine, because we did a lot of telemedicine follow-up to these really remote villages in the Amazon. And that was kind of laid the groundwork to a lot of kind of my exploration. I continued to do a lot of international work throughout residency training and a lot of short-term mission trips with a wide variety of organizations. And then when I completed my plastic surgery and craniofacial fellowship, I took an additional international fellowship year with an organization that was at that time called Interplas, now called Research, and they had a one-year Webster fellowship, which allowed me to go on, I think I went on 13 short-term mission trips around the world, and also spent a lot of time with residency training programs in different parts of the world. And from that, I kind of pieced together things that I thought worked and didn't work, and built my own nonprofit. And I'm here in San Diego, where we have a pretty interesting cross-border network that ties into a lot of the stuff we do in other parts of the world.
Very, very cool. And thank you so much for taking the time to be with us.
Yeah, my pleasure.
And I'll go ahead and introduce our other panelist tonight, Dr. Marky Walker. Dr. Walker is an assistant professor in plastic surgery and orthopedic surgery at the University of Mississippi Medical Center. This is after he did his training at Yale, which is where I was able to get to know him a little bit and work with him. Dr. Walker, like Dr. Gosman, has done a whole lot of different things, and I'll let him talk about that a little bit more. But I've been able to work with him in an organization called Hand Help, which is basically a medical mission-based organization that does hand surgeries. And so I've really appreciated working with Dr. Walker in that regard, and I'll let him talk a little bit more about his involvement in global surgery and what he's done.
Thanks, Connor, for the introduction, and it's a pleasure to be with everyone tonight. So like Dr. Gosman, my sort of path into medicine was largely inspired by exposure to international medicine and surgery, and ultimately my decision for subspecialty was driven by that exposure as well. A couple of different models had an influence on that. But my beginning with international medicine really happened in college for me, and so the concept that students are involved in global surgery and global health is something that has been really a touchstone for my own path into a career in medicine. With a buddy of mine in college, we decided we wanted to see a little bit more of the rest of the world and some of the challenges that were being faced from the medical side of things as pre-med students. And so we founded an organization and got a big group of people together and some institutional support. And that was actually my first time ever traveling out of the country. And so my viewpoint on what life was like outside of the United States was basically flyers for tropical vacations across the globe, but really my first adventure was in Montero, Bolivia, which is probably the poorest town in the poorest country in South America. And it really changed my life for the better and really put me on a path to begin trying to develop a skill set beyond my own interest and energy on this topic to actually be able to go and do something important and valuable for people that don't have access to the care that we have here. And as my exposure to mission-based settings has increased, I've also started to gain more insight into exactly some of the larger problems and hurdles that we face globally in terms of access to care. And so as a result, thinking about how me and my team and the people that I've had a pleasure to work with on these missions and sort of with the same objectives can expand our reach and build capacity has been sort of on the forefront of our thinking and writing and working with other organizations like the organization that Dr. Gosman has founded. So it's a real pleasure to be able to share that work and to field some questions, because I think this is the perfect time to get involved when you're right in the middle of it, right at the very beginning of this exciting path that you've all chosen to take.
Thank you for kind of giving us the background, Dr. Walker, and Dr. Gosman as well. We're going to jump right into these questions. This is admittedly a very broad topic. It's really hard to answer all of this in 50 minutes, but we appreciate any of your insights and hope that we can have some good discussion. Our first question is really kind of at the core of the topic tonight. Really, plastic surgeons have for a long time been at the forefront of global surgery, and a lot of that work has been based on going and performing surgeries abroad, and we've done a lot of work in that regard. That being said, in recent years, kind of the focus in global surgery has started to change a little bit. And the first question that we have for each of you is, how do you see the actual landscape of global surgery changing? And then more specifically in global plastic surgery, how have you seen it change, and how do you think that the landscape of global plastic surgery is changing moving ahead?
Which of us would you like to speak first?
If Dr. Walker, if you have something to say, why don't you go ahead?
Sure. I think that it is a constant moving target as the world changes more rapidly, probably in the last decade than before it. And one thing that I've seen happen, which I know Dr. Gosman can speak to very thoroughly, is the use of telemedicine and remote connectivity that's sort of allowed us to expand our ability to have impacts in these communities. And you know very well, Connor, because you're working on this project right now, that using social media and telemedicine to be able to follow up, to be able to field questions post-operatively, to be able to advise and help and seek the advice of the teams that we work with on the ground that may not be a member of our organization, but the hospital staff and other surgeons that we work with when we're abroad, to be able to connect to those people and give real-time, real answers that directly in that moment impact care and rehabilitation, especially for hand surgery, has been a dramatic thing for our ability to play a part globally. So, I think that's probably, at least in my experience, the most impactful change that's happened recently, is the fact that we're all so very connected and able to connect across the globe in a moment.
Yeah, I would definitely agree to that. I think it's been really, obviously it's been a lot of tragedy in this whole pandemic time period, but I think, the flip side of any crisis is there's always incredible opportunity and innovation. And, we've been using technology for a really long time, and it's been frustrating to see how difficult it was to really integrate things like telemedicine and virtual evaluation into domestic practice, whereas it was so much easier to actually do internationally just because we weren't worrying about getting paid, and then like overnight, like the lights switched on and we're able to use telemedicine. And we've actually, it's funny because Zoom, for example, is one of the few like HIPAA compliant platforms that's been around for a really long time. So we've been using it for telemedicine follow-up, for speech therapy, for all like clinical evaluation for I think 7 years or something now. And we're originally like helping them out, doing some promotions just to tell them about the use of international telemedicine. And now, of course, they're like going to be like, you know, billionaires. But I think that, you know, there is incredible opportunities for technology. I think when we look at kind of how the landscape of global surgery has changed with the advent of the Lancet Commission and bringing that to the forefront of the world agenda of health, has made a tremendous impact on our ability to really start to analyze the issues that are impacting different subspecialties of surgical care, and to start thinking a little bit beyond what we can do in a week or 2 week visit, but what we can do kind of as a collaborative group in terms of building capacity for areas to provide sustainable care. And I think, you know, the key to that is a lot of it is education based. And that is another thing that I think has been a wonderful outcome from this pandemic, is watching how much virtual education has now taken a hold of the whole world, and the world is really becoming so much smaller. So, you know, there's so many institutions that are sharing their educational material. There's been fantastic programming coming out of a lot of different parts of the world. And I think that holds a ton of potential for really just connecting, you know, providers in different areas and helping them to share resources.
It's really an incredible thing that has happened with remote access, because, you know, the organization that I'm with now, we were trying to figure out, is the work we're doing actually effective? And I remember sort of celebrating the concept that we sent someone back 6 months later to go and track down as many patients as they possibly could that we had seen, just to find out if what we had done worked, and sort of where the patients were at that moment in rehab. And that was just a huge congratulatory accomplishment. But now you can do that like 30 seconds with the push of a button. And so it really has changed things. And I'm excited to see how that allows us to transition from these 1 week, 2 week missions to really a prolonged, lasting impact on the patients that we're seeing and those communities. So, but that doesn't happen without partnership on the ground. So it's still very important, beyond just the phone calls, to have people there who can actually help you.
Thanks so much for telling us about how you guys see that changing. So we're going to jump into something a little bit closer related to the topic tonight, and ask about what each of your opinions are on the short-term medical mission model, how you would define it, and how you also define surgical capacity building. And we'll start this one off with Dr. Gosman.
So, you know, I would say that the short-term mission trip model has some role. I think that as educators of surgery, the way that we teach and that the way that you learn in surgery is a hands-on approach. So I think that there is certainly a role for having, you know, people visiting and doing surgical care, and kind of that, you know, engaging them in that model of training, just like you would if you were a resident being trained in this country, or if you were working with another, you know, provider. I think there are a lot of problems with the traditional short-term mission trip. I think, you know, I can just tell you a few things, you know, that I saw early on that were devastating to me. And it's not organization dependent, but things that I never really wanted to ever have to, you know, be a part of again. And I think the main thing that I have learned, and being in this location where we're on the border, I've been a member of our cleft and craniofacial team and have essentially a Mexican partner that I've been working with since I moved here, I've had the opportunity to really see things from multiple angles, because I see a lot of what happens from the short-term mission trips that I never would have seen before. So all these things are like, did what our surgery help or not? And, you know, certainly it can help, but certainly it can really hurt. And there are, I think, a lot of the problems with the short-term mission trip isn't just like inherent necessarily in the model of going and doing surgery in a place. I think it just depends kind of on the structure of what your collaboration is with the local providers. And there's a lot of kind of nuances to it. I can tell you that early on, when I started, you know, short-term mission trip participation as a resident, I remember going to a hospital. We went to a hospital in the Dominican Republic every year. And I remember doing a burn scar contracture on someone's leg, and we came back the next year, and we had released this burn scar contracture, did a skin graft, and came back the next year, and it was significantly worse because they didn't have splinting, they didn't have physical therapy, and didn't have all this aftercare. And the issue is, for a lot of what we do, whether it's burn reconstruction or hand surgery or cleft surgery, which is a lot of what you're going to see in, you know, low and middle income countries, the surgery is pretty much like the straightforward part. It's all of that difficult rehabilitation afterward, the wound care afterward, the speech therapy, and all of those kind of nuances and the follow-up that are really, really important. And that's kind of what led us into really integrating telemedicine, is because we, once we started our organization, there were other people who had reached out to us to treat burn patients. I was like, absolutely not. We're not going to do that unless we have the infrastructure in place to be able to provide adequate follow-up care and make sure that the outcome is actually going to be better than what it would be if we just did surgery and left, which we could see time and time again was making patients worse. The other thing that's really, you know, problematic about short-term mission trips is that there's a lot of variation in organizations and how they vet their volunteers. So there are, you know, it's really important that, to me, and I think to anyone who's operating in a global space, that you should be doing the same quality of care that you do at home. And I'm not going over to a different country and delivering babies or fixing femurs. Like, I'm doing what I do every day in my day job. And a lot of the problems that we see from, you know, some of the short-term mission trips, especially the ones that we see that come over the border into Mexico, and that, you know, it's people that are operating outside of their scope of practice, who do this for like a week of the year. And, you know, it's, you don't know what you don't know in a lot of those situations. So I think it's really important to kind of stay in your lane, do what you do. And more importantly is really having a local partner that is your stakeholder that you're developing all of these plans with, because you can go somewhere and be like, oh, nobody's taking care of these patients. And a lot of times there could be incredibly skilled surgeons that are working within this region, but they may be disenfranchised for other resource related reasons. So I think it's really, really important to integrate and establish yourselves with the local healthcare system and stakeholders, and develop a plan really in partnership with them, that it's not okay to just say like, these kids don't have any other chance, I'm their only chance.
Yeah, I couldn't agree more with those points. I think that there is a role for sure for short-term medical missions, but with one caveat. You know, I don't think that they should be viewed sort of as one-off. Like, saying short-term medical mission, and there are many that are sort of one-off missions. You find a place, maybe someone expressed a need, you go down without having ever been there before, with a poor understanding perhaps of the workflow and the logistics and what the actual need is, show up, you find yourself, whether intentionally or not, in a situation where maybe expectations are that you're going to play outside of your lane, which is completely inappropriate. This is not sort of an adventure into the unknown. I think that concept of it being something where you're seeking out the things that are super rare, and you've never done this surgery and you're very excited to do this surgery, that would give me quite a bit of discomfort and fear, which I think is a healthy fear, because the entire objective should be that you have spent the time and energy and you have this sort of passion to share a skill set that you ideally will be sharing on an equivalent basis as you would in your own clinic, in your own operating room, with the same resources. So I do think that short-term medical missions can be done and have a role, but they have to be done right. You have to go in knowing what the need is. I think advanced work is actually really important. For instance, and we may speak to this later, we often find ourselves where maybe the politics or the community changes where you are. And then you have to think, well, am I going to continue to go to this spot? And it's always very difficult to make the decision to leave a spot where maybe you've established relationships and you have an annual expectation that you're going to be there. And it is like a very bad breakup, because you've created these relationships, but maybe the politics of it falls apart. You can't expect to know all of those facets of the places where you're going to go without quite a bit of research, probably going down ahead of time to see who are the people that you're going to be working with, what is the need, what resources do they have. Our organization goes down with the expectation that we will use nothing that exists there, because we don't want to deplete resources. So in trying to create this exact same environment where we're operating here, we bring our own equipment and our own supplies, our own wound dressings, our own suture, our own gloves, everything is our own ventilators. We have all of our own stuff. So you can control the things that you can control. But if you get there and you have maybe community leaders who haven't quite bought in, or maybe the hospital administration hasn't quite bought in, without establishing those sort of more social relationships ahead of time, I think it will be completely ineffective, and probably will, in a sense, be a very acute tip of the spear type interaction where you leave and maybe you've done a couple of surgeries, but the long-term impact in a place like that without the knowledge going into it is very small and probably more harmful than good. So, I think ultimately there is a role, but it has to, for short-term medical missions, but it has to be done right. And our objective is to basically envision it as if we're always going to be there, in the sense that we at least leave knowledge or education or something, so that the surgeries that we're doing can be perpetuated, and so that we can continuously communicate with the people who are there, the medical providers and the rehabilitation providers, so that it's not, in a sense, a short-term medical mission. That just happens to be, the trip itself is just one component of that.
I think Dr. Walker cut out for me. I don't know if he cut out for other people.
He froze for me.
Dr. Walker?
Yes.
You cut out, and I think in your last sentence there. You said it's one part of.
I see. So I was just saying that the 1 or 2 weeks that you're there visiting, I don't think that you can view that as the entire mission. That's just one very small slice of what hopefully will go forward with working with the people who you meet and the relationships that you establish, so that care can continue even in your absence.
Right. You both talked a lot about the importance of perioperative care and being cognizant of developing relationships there that are long lasting. How do you think that the short-term mission model will develop closer into long-term relationships, and how do those two interplay with each other? Because you both spoke about considering that perioperative period, but how do you account for that when you're not there?
So I think, for me, it's really about partnership. Like we're not, I think that there's limited utility of going someplace and trying to do a bunch of cases and leaving. I don't think it necessarily can be helpful. It certainly can be hurtful when it's outside of the context of like a greater capacity building effort. So in order to build capacity, it really has to be a partnership for the local stakeholders. And that's where that has to start, I think, in order to really invest in infrastructure and sustainability. So for me, that relationship is the first part of that, and establishing that relationship. And it could be, you know, in some places where there's really limited access to surgical care, it's not always like a plastic surgeon that's there. It could be a general surgeon, or it could be an oral surgeon. But establishing a partnership with the individual and being able to work through and kind of align what the needs are is really critical. And that, you know, anything that would be done on a short-term mission trip that we would participate in would be like really aligned with an educational objective, and trying to meet the needs of kind of whoever we're collaborating with.
Yeah, I definitely agree with that. I think that when we initially begin exploring new locations, a top priority is to make sure that we build a relationship. We find someone on the ground who that hospital or that community has designated as the person who's going to help us to get there. And then that same person is the person we would coordinate with for resource generation, for developing an educational curriculum that suits their needs, their specific needs for that community. Every time we travel, we have basically a mini symposium of topics that are selected by the hospital that we visit. It's always the same surgeons. We make sure to connect with program directors, because a lot of these hospitals are academic hospitals, or at least they're learning sites. I don't think I've been to, and maybe Dr. Gosman can speak to this point, I don't think I've been to a hospital where there has not been a resident or someone very early in their training, sort of a resident equivalent, or someone who's doing 1 or 2 years of national service right after they finish training. And those people, I find, are always extremely hungry for knowledge, and they want to work with you and talk to you and ask you, why do you do it this way and that way? And that for me is one of the most fulfilling parts of the trip. Doing surgery, we do surgery every single day in our own jobs, but being able to carry that skill set and expand on it and actually answer a specific call to fill a specific need, I think is huge. One of the questions that came through this board about how to establish relationships, I think it's not just establishing the relationship at the hospital you visit. I think it also, often in order to get the visas and travel things that you need in order to actually conduct a mission, requires being in touch with your local consulate, who can often direct you to people in the communities that you plan to visit that may be good resources for you, so that you can start getting the answers, such as, you know, what do you actually need? Because we can operate all day long, but if you need education, we need to build that into it. If you need us to develop, educational materials to pass on to the community, we can help do that. But it's not something that we would want to come to and leave without knowing that someone is going to be there when we leave to carry that work on and be able to expand upon it.
Yeah, thank you both for, your answers. We're touching a lot of the points kind of in all the questions here, because it's all sort of related. Something that, you both kind of mentioned is the importance of teaching and training. One question that we have here is there still, from your experiences, really that need? Does that need for people to go and perform surgery still really exist? Is it changing with these training programs in other countries? And if so, how do you think that these medical missions best do assist? So I guess I'm saying is, do you think that there still is a big need for this training and for these missions? And if there is that need, where is that need? How can you as a mission team go and fill a specific need? What do you think those needs are?
I do think there's that need. I've had the experience where even with the effort to bring an educational program, it's really difficult to teach someone to do multiple highly complex operations that maybe they've never done in a week or two. And so this speaks to one of the weaknesses of short-term medical missions, is that you go down with the objective of maybe not only performing these operations, but also teaching the local surgeons, and not necessarily plastic surgeons, as Dr. Gosman pointed out, to be able to do the procedures that their community demands. And it has been my experience that sometimes we return and still there's a massive backlog of these operations that we were doing, and it turns out that maybe they did one or two but didn't feel really comfortable, and then we start to think, well, did we fail the last time? And I don't view these things as failures as long as you're committed to going back and teaching again. But I do think the model needs to change, and with the access that we have now remotely, I think we could probably do a better job of teaching. But I do think it's still absolutely critical in many parts of the world that there are surgeons who are willing to commit time and energy and resources to go and try to spread this knowledge. And I don't view it as go and try to do as many operations as possible. I think that the objective should be to go and teach and try to make a lasting impact so that we can build a capacity of surgeons in these areas to do the operations that they're asking us to do.
Yeah, I agree. I mean, I think it's widely variable in different parts of the world, but there are certainly, a huge need in a lot of parts of the world without really access to surgical care. And so there is tremendous backlogs, and especially looking at like different countries in Africa and the College of East, Southern, and Central African Surgeons, which is the kind of overseeing body of their residency programs and their board certification. And they've been starting up residency programs in a lot of countries within their region, but it's still very, very small, and there aren't that many surgeons that are available to take care of their population. So there is a tremendous backlog. I think the other thing that's really important when you look at these things is that it's really important to look at the bilaterality of it. So why are all these people interested in doing this stuff? Like, you have to realize that, and for those people who've engaged in different global health activities, it becomes pretty obvious that you learn as much or more than what you're passing on every single time. So this is very much an exchange process, and I think that we have so much to learn from our international colleagues, from working in areas where resources are limited. I mean, our healthcare system is a expensive disaster, which really came to a head during this pandemic without coordination and relying on market forces for PPE that should have been available to everyone if things were coordinated. I think that we really have a lot to learn, and that anything that we engage in isn't just us going to help someone else. Is that we're learning. There's opportunities for collaboration, there's opportunities for developing research that's mutually beneficial, and that there's always going to be benefit in those types of collaboration. So it's important to kind of reframe it so that it's not always kind of us helping someone else.
Thank you for answering those things. You mentioned going down with a broader group of people. When you go down, one, what type of procedures do you both perform? Are some of them cosmetic? And then secondly, with the group that you go down with, is that a group of plastic surgeons, or does it rotate through different surgical subspecialties or surgery or different types of surgery?
So most of our activity is really education based. So we don't really do, through my organization, we don't really do short-term mission trips, but we have done them in the past in order to start up educational programming. We do work with our partner sites. For example, in Tijuana, we will do surgery with our colleagues there as part of our international craniofacial and cleft team, and those are mostly cleft or craniofacial cases that we do there. We do like some hand surgery where we can bring hand surgeons with us. It's always structured around an educational event with usually some type of visiting professor that is broadcast as an international kind of telemedicine educational opportunity. So we always like are bringing people anytime we're operating that are kind of working within their own subspecialty. One of the things that our partners have really kind of engaged us in terms of helping to expand their capacity has been in the region of multidisciplinary care. Again, I think it's always like pretty easy to like put a surgeon somewhere, but to really build a team that can take care of a lot of the other aspects of the success of what we do when we're doing cleft lip and palate surgery really depends on, you know, us having a good speech pathologist, of having audiology, of having geneticists, and all of these things. So we work really hard to try to provide multidisciplinary care and provide training for multidisciplinary care to help support a lot of the teams that we work with in other parts of the world. And then, you know, there are other, you know, areas that we have longstanding collaboration on, but again, it kind of just depends what that region is in need of. There's places, you know, that we work in Vietnam and Indonesia where they're really expanding into microsurgical reconstruction, and they have a lot of vehicular trauma and motorbikes and things like that. And that's where their area of interest is. And then, you know, there's partners that we have in Africa where a lot of it is, you know, really related to the morbidity of burn care. So it just kind of depends. It's very widely variable.
So in contrast to that, the organization that I'm working with now was founded specifically to deliver hand surgery for children. And so because we do try to match the exact same care that you would expect at an institution in the United States, the surgeons that we bring are only fellowship trained hand surgeons. They may be plastic surgeons or orthopedists, but they not only completed their plastic surgery training or their orthopedics training, they've also specifically done fellowship training and have either positions in that field or credentialed in that field. So one of the messages on the board asked about staying in your lane. That's specifically how we've tried to stay in our lane surgically, is to bring fellowship trained hand surgeons. In addition to that, we bring hand therapists, and not just physical therapists or occupational therapists. We only bring therapists who have the CHT, which is Certified Hand Therapist Credential, which is beyond their training as occupational or physical therapists. And so the specific objective is to go with people who are the most trained individuals in that field to meet that specific need, and with the resources that we need to both preoperatively and post-operatively manage the problems that we're seeing. That's something that now with the advent of better telemedicine, we've been able to expand because our therapists are in communication with the therapists on the ground. And I'll tell you that a part of sort of the advanced work of identifying a location where what you have is going to be most impactful, we found that some places nationally just don't have therapy as sort of an organized profession. And so if you are operating on disease that demands rehabilitation for outcomes, the surgery is going to be useless and probably very dangerous and damaging if you perform it without someone there who can continue that care from a therapy standpoint. So we've been very lucky in Peru most recently because they have an organization of therapists that are specifically interested in hand therapy, and part of our education platform is to do that symposium with them, and they teach us and we teach them the different modalities that have been shown most effective for the people we're operating on and for the ones they're operating on. And it's been a beautiful relationship in that regard. So the beginning of the question was, what surgery do? We do all pediatric hand surgery, and that may be acute surgery, it may be congenital, syndactyly and polydactyly, it may be delayed trauma. So unfortunately, we see a lot of maybe a kid. I think, one patient that stands out in my mind was a 14-year-old boy that flipped over his handlebars and broke both distal radiuses. And that happened, I think, maybe 2 months before we got there. So it wasn't, super chronic injury, but it was beyond the easy comfort of the operation that we would typically do, if the kid was riding his bike next to a level 1 trauma center. So we do all of that, but it's mostly hand surgery, and within that, there's burn surgery because the hands happen to be a place where people often sustain thermal injuries. So it's pretty broad, but hand.
Thank you both again. Kind of going off of this staying in your lane and making a little bit specific for our audience here, which is mostly medical students. Obviously, both of you said you were interested very early on, medical school or before then, residency. As medical students trying to get involved in global surgery, what can we do as far as what is the lane of a medical student who obviously with the ethical questions, there's a whole other layer with that as a medical student trying to be involved, which is a question even in the US when we're being trained. But for the people here on this call, what do you think is the lane that we can stay in, or a role that we can fill as medical students?
I mean, I think, it's always like a pretty good litmus test to just kind of flip-flop your circumstance, right? So I always kind of think about, when I hear about these situations where like in some of our Mexican partner sites where they have these incredible multidisciplinary cleft lip and palate centers, there's like 24 of them now around the country, where they have a volume of like 250 clefts, which is more than any center in the US. And like a team of like cosmetic surgeons come and does a bunch of cleft surgery for a week and leaves. I just try to imagine like, how would I feel if somebody came to like my parking lot at my children's hospital and like a bunch of like Mexican doctors came there and were like, okay, we're gonna go operate on your patients. So like, just like flip the situation and try to like keep it real to what should be quality care, and what is like your gold standard of what you do here. And that should really be kind of your litmus test. When we think about like vetting organizations, we did a study several years ago of the ASPS membership, looking at a wide variety of volunteers, and it was a wide cross-sectional study. But we just looked at basic quality metrics. What I said about staying in your lane: are people operating in their scope of practice? Do they have follow-up care? Are they keeping medical records? Are they using an appropriate anesthesiologist? If they're operating on kids, are they using a pediatric anesthesiologist? Anything that wouldn't fly in the US that's happening somewhere else should definitely raise your suspicion. And if somebody starts to get into that mentality where like I'm their only chance, you always have to remember like surgery does a lot of harm. And if you're not there to kind of see what happens in the aftermath, then you can't just let this stuff go into the unknown. And I know it's challenging as medical students, and I will tell you for sure, like having gone on so many short-term mission trips at different stages of my career, it's amazing. It's super fun. There's nothing like, being a part of a team and everybody's on this high and you're in this incredibly unique environment, but you have this inside track because you're working with local providers and you're doing life-changing surgery, and then you leave and you don't really understand necessarily what happens when you leave, or all of the implications of even you being there have on the local health system. If people aren't getting trauma care because you're taking over their OR, if you're being brought there by the mayor's wife who is running the public health department, which is what happens in Mexico when you become mayor, your wife takes over basically the public health oversight over the clinics, and you're doing it there for some, for re-election, and you're feeding money into the financial sector. There's all kinds of implications that you want to really keep an open mind about, and just use your own kind of standard of care as your litmus test.
All great points, and those sort of many of the things that I didn't see when I was an undergraduate student and a medical student on these trips are becoming more and more apparent the more into these organizations I become involved. And the point about sort of the politic influence on it, I think, is maybe something that you wouldn't recognize at this level, because maybe you're not making the arrangements for how you're going to get all of the equipment through customs until someone, you know, tries to get something out of that process that maybe you know, doesn't seem quite above board. So I think there are things that happen that maybe you would miss as a medical student actually going, but obviously there's many benefits to going, and I think there's a role for a medical student on a trip if there's one that seems appropriate to your perhaps your interests medically, and obviously you're all involved in this great organization. This being involved in the GSSA is a great way to begin exploring your interest in global surgery, and I think participating in panels like this and submitting questions so that people that are doing it can give you their point of view, I think is a great place to start. When I was a medical student, there wasn't as much freedom to travel as I had as a college student, because there wasn't a summer every year for me to enjoy and be able to, you know, hop on a trip. And so what I did was I decided to do a rotation at the Shriners Hospital, and that's a whole different model of being able to reach beyond the hospital walls to treat patients. And that, you know, that's sort of the fly-in model in a way. I know they also have outreach, but from the medical student side of things, it was fascinating for me to see the good work that these surgeons that were operating at the level that you would expect of the medicine that we hope to deliver are doing on very devastating injuries that maybe we don't see as commonly in some places in the United States. And so if you want to see the people and the type of trauma and the type of congenital problems that they present in a mission type setting, maybe the first place to start is to find somewhere in the United States that's doing that type of work. And there are Shriners hospitals and Scottish Rite hospitals and Le Bonheur Hospital. There are several different places that probably are affiliated in some way with your medical school, where you may be able to arrange a rotation or a visit. That may be a good place to start. I think, unfortunately, travel, and I'm seeing this in my own organization, is restricted. And so it's interesting. It's going to be interesting to see how the medical mission model comes out of this.
Definitely true.
But there's plenty to see here, even if you can't leave. So.
Thank you both for those responses. Those are great things to consider as students interested in this work to consider before you go down or work with a certain organization. So you both brought up politics, and this one's directed mainly at Dr. Gosman. As you moved into the nonprofit educational realm, how has local politics been easier or harder to work around with like governmental support, and also have funding models for the nonprofit organization that you run or in the educational realm been easier to find funding, or has it been harder to find funding because it might not be as sexy of a sell as a short-term medical mission?
Yeah, it's definitely true. The fundraising is a challenge, and I think also like a large source of the ethical dilemma of you know, global outreach. That, you know, there's nothing that really like makes people open their checkbook more than like seeing a before and after of a cleft lip, and everybody knows that, and that's why they have, you know, these like really kind of unethical pictures of poor children sitting in the dirt crying, you know, and looking as like just disenfranchised as possible in order to raise money. And there's a lot of issues about that, and that's where, you know, kind of the flip side of the amazing advent of technology and social media, you know, has to, you know, always be tread with a little bit of caution, because these, you know, you can't imagine like if you took a picture, if somebody took a picture of my kid and put it on there, they could be sitting in the dirt and looking pathetic too, you know, and put like donate now. Once you put that like donate now sign on a dirty crying kid, it's a whole different message. So I think that that's something that is really challenging, and you have to, there's kind of an ethically nuanced use of technology. But certainly raising money for educational outreach is very difficult. People, it's hard for them to wrap their mind around capacity building. It's hard to sell that, and it's hard to sell it as like kind of one step removed, like, oh, we're going to help the kids by helping to establish a system. And it's more than, you know, usually just an elevator speech or like a quick video clip. And we definitely haven't entirely figured that out. But it is something that for our nonprofit, we've invested really heavily in. We have a fellowship program and research program where, you know, we train fellows from different parts of the world and bring them into our network for hands-on clinical training. And they work in US institutions as well when we were able to travel. But that's much harder to raise funding for. And that's something that we're definitely grappling with, trying to rely a little bit more on like grant funding and educational endowments is kind of the angle that we've been taking. As for politics, politics are really, really challenging and just kind of throw a monkey wrench into everything. And just when you could be working, and I mean, we were working at a site in Guatemala for a really long time, and like all of a sudden there's like a political regime and the whole thing's like wiped out. So it's really, really challenging, and you never kind of know when that's going to happen. I think one of the key things that we've learned from that, and kind of part with the people that we partner with, is traditionally a lot of the infrastructure that's provided to visiting teams is usually through a Rotary and through like whoever is kind of holding political office. So those are things that, you know, if you're partnering with some body of people that are going to be there in perpetuity, it's going to be more stable. Whereas if it's coming through a political figure, it's going to be obviously less stable and more temporary. And ultimately, really trying to partner with whoever is really your counterpart, who has the most knowledge of what you're doing, and that's going to be the most valuable and sustainable thing, because then you can kind of grow together and weather the storm of political change a little bit easier.
That was great advice. Dr. Walker, if you want to talk also about how you've met with political figures, and if you've experienced a similar thing as partnering with a political figure versus partnering maybe with another physician or your counterpart there.
Yeah, I think I would just echo what Dr. Gosman had said. I think that you have to appreciate that politics is extremely unstable, and if you have one elected official that, you know, really supports your work and the changes, it can end overnight. I mean, we had to leave Honduras and Nicaragua when political instability happened, and it's not just leadership changes, because sometimes, as you know, if you watch the news, you know, a single election can change things from peacetime to wartime, and that changes everything. So I don't really have much more to add. I think that's right on.
Thank you both for that. There's a lot more very interesting discussion points, and we've only hit on a handful of them. Before the time hits, just kind of the practical question again for the students here. As we move forward, most of the people on this call are interested in plastic surgery in some extent. Do either of you think that there's still a place, or that there will be a place for academic global plastic surgeons in the field of plastic surgery? And as we look into residencies and look for programs to go to, is that something that we should consider? And is that something that people will consider when they look at us? In the sense of, does it change people's perception as we go to a program and say we're interested in doing global surgery? So I guess the summary is, how can we move forward with interest in global surgery and plastic surgery, and then inquire about that from residency programs?
Yeah, I think it's really, I mean, it's very, very common. I think there's a high demand from, you know, students and applicants and residents for learning in this space. So it's very much something that, you know, the academic plastic surgery acknowledges and is trying to kind of organize and expand upon. I've been involved in several of the efforts that have gone through our ACAPS, our academic society, to build our global surgery capacity. And we had our winter retreat this year was on global surgery. And then through, our national society, through ASPS, I'm been working, because I'm currently the chair of our VIPS committee, which is the Volunteer and Plastic Surgery Committee, but we've been working with the Plastic Surgery Foundation leadership to actually create a more robust arm of the PSF that's going to be really dedicated to international capacity building, with a international learner community and an international educator community, and then a research arm. So that's something that we were planning to, that we've been working on for the last couple of years, that we were going to roll out at our plastic surgery meeting, which probably will also be virtual. But there's tons of interest in it. I think almost most programs have some type of involvement. I think it's just really a long tradition within plastic surgery. And I think that we really acknowledge that there's a ton of, benefit from collaborating with people in other parts of the world to try to provide, more robust plastic surgery access.
Yeah, I think pretty much. I think you'd be hard pressed to find a significant number of academic plastic surgery programs that don't either have a well-established history of doing this type of work, or a specific, maybe not a requirement, but something that pretty much every resident does during the course of their training. I think that it's some of the most meaningful educational experiences that I had during residency were going and meeting residents who were training in other places across the world that had similar questions as I do about certain procedures, and being able to just sort of find ways to connect that were so far beyond our national identities, but just out of just people who are interested in learning. And I think the role of academic surgeons in this field is massive. But the whole reason why most of us chose to go into academics in the first place is because we have this sort of desire for lifelong learning, and we like collaboration, and we like collaborating with partners at other institutions and in other specialties. And I don't think that expressing an interest in that would be harmful at all for someone interested in going into plastic surgery or any of the other fields that tried to do this work. I think that it's something that is accepted widely and is cherished by many of us.
Yeah, I would definitely ask programs, what they are able to offer in terms of their international opportunities. And, one of my goals is to make it much easier for people to have, rotations. Now we still have to go through quite a few hoops, but it is feasible to have, international rotations that count. And I think, we're evolving to a place where it's going to become easier and easier, at least, to get credit for that time. But those are things that you should definitely be discerning about when you look at programs and what the opportunity is.
Great. Thank you so much, both of you, for all of your time. We don't want to hold you any longer than you promised us, which was 8 o'clock Eastern time, although we have people from all over the place. If you need to leave, feel free. We understand the surgery. If you guys have anything else you would like to, share to all of the medical students here, any thoughts that we didn't touch on that you think is really important, that you'd like us to know before we let you leave, please feel free to share those. If not, we can let you go and get back to your work.
I would just like to echo what Mark said. I think, really throughout all of my education, definitely the things that I learned the most in were all of my international experiences, and especially the time that I spent living in country and other places. And I don't get so paralyzed by your concern about whether the short-term mission trip is good or bad that it prevents you from exploring these opportunities and kind of assessing what's going on. I definitely just, encourage you to always be discerning and to always use your voice and try to really explore kind of behind the scenes, like what happens, you know, after people leave, and, you know, what happens, you know, in terms of who's benefiting from your visit there, because I think it, you know, I definitely didn't know a lot of that when I started out, and it was an incredibly fun, you know, adventure so many times. And it wasn't until like started to see some of the unfortunate consequences I started to really look into the other side of it. And now being able to see both sides, you know, I can see things that definitely aren't readily apparent from, you know, kind of just a regular team member. So there's always another side of the story. And I think that, you know, just be discerning, and you guys have a lot of value, and take advantage of a wide variety of opportunities to kind of see what you think works best. I think we have a lot of potential with, you know, really trying to support training programs. And for me, when I looked at all these different models, I always kind of fall back to the Chang Gung model, which was really a situation where a missionary group went and, you know, realized that there was a lot of congenital problems that they wanted to take care of. And instead of just doing short-term mission trips, they started the initial surgeon went and did plastic surgery training, and then went there and started a plastic surgery residency. And now it's like one of the top training centers in the world, and just a leading innovator of plastic surgery education. So there's all kinds of things are possible. I think starting training programs and supporting training programs just really like will help us to battle access. But there's a lot of ways to do it, and a lot of different roles that we can play. So I would just encourage you all to explore and take advantage of any opportunities that you have.
I would agree with that. I think that you're at a time where you have the luxury to be able to continue exploring, and a little bit of freedom to do that with elective time perhaps. And if you're interested in global surgery and you have an opportunity to go and visit with an organization, you know, do some background research on it, talk to people who have been with that group before. And I think that you'll find that you learn a whole lot more about yourself maybe on those missions than necessarily the operations that are being performed. But 100% my experience pursuing this work has guided just about every professional step that I've taken, and still continues to influence the types of surgery that I most enjoy. And I will always continue this work if it's possible. So I think this is an exciting time for all of you being medical students, and there's so much opportunity out there. Just do your due diligence before you sign up for something, and take mental notes of all aspects of that adventure, not just the surgery part.
Well, from the GSSA and in behalf of all of us, we want to thank both of you so much for coming and sharing your thoughts. We really do appreciate it. And we hope that we'll be able to see you in some of these small global surgery conversations again further down the line. But really thank you both so much. We really appreciate it.
Absolutely, my pleasure.
Thank you everyone for coming.
All right. Thank you.